My name is Mohamed Oraby. I have nothing to disclose. My case is a 63 years old male patient with hypertensive and diabetic, stable coronary artery disease with positive treadmill test. 2 weeks before, he had a PCI with DS for the LAD and LCX. His echo was non-remarkable, with ejection fraction was about 65, ECG non-conclusive. Our plan was to fix RCA CTO. Our strategy was first to do antegrade wire escalation. If failed, we do antegrade dissection entry. This was his coronary angio. We can appreciate the stents in proximal to LAD and LCX that was done before, and RCA CTO getting retrograde from septal collaterals from the left system. And this is RCA coronary angio. We can appreciate proximal CTO with faint antegrade delayed flow. So our strategy was using a 7 French short tip AL1 with using Sion Blue guide wire that successfully crossed to the distal PDA under support of fine cross microcatheter. We tried first balloon advancement under guideliner support, but the balloon didn't inflate properly. Then upgraded to a bigger balloon, but still failed to open the lesion. So according to Dr. Black's strategy, we decided to shift to atherectomy using rotablation. So we changed the guide wire to rotawire using 1.5 rotabur at 180 kRPM. For 30 seconds, the patient developed bradycardia, transient AV block, and hypotension. That recovered spontaneously after atropine 1 milligram given. Then we noticed ostial RCA dissection, maybe from the guiding, maybe from the rotabur itself. So we changed the guide wire, trying to advance another microcatheter using turnpike gold that was stuck and was retrieved using the guide liner. Another balloon, a bigger balloon, but also failed to open the lesion using granuloplasty, using several balloon size, but still not working. So we decided to use another rotabur with a smaller caliber, 1.25. But at that time, the rotabur was incarcerated at the mid-segment lesion. So we cut the rotabur using the Y connector was removed, advancing ST01 guiding catheter under non-invasive blood pressure monitoring, using UP3 guide wire, and then changed to Conquest Pro 12 that passed behind the rotabur, and using a small balloon that was inflated at the rotabur incarceration point. At the time, some retraction using the ST01 again, and we could retrieve the rotabur successfully. We noticed the spiral dissections extending from the ostium to the mid-segment of RCA. So we changed the guiding catheter, and the system, of course, was retrieved with the retrieval of the rotabur. So we changed to 6 French GR4, advancing run-through guide wire, and pre-dilatation again. At the time, the balloon was inflated properly using IVUS. Showed some cracking of the calcification and the dissection, of course, and the wire was in true lumen. So we started the stenting from distal to proximal using 2 long DES up to the ostium of RCA, post-dilatation, doing IVUS again for getting confirmation of the stent deployment and opposition. And this was the final result for the RCA. So my take-home message is dealing with heavy calcification is still a big war that need every weapon we can use. Having a plan and alternative plan is your key of success. You should know how to deal with every complication using appropriate tools. When dealing with complication, first step is to keep calm, think carefully what's the problem and how to deal with. And thank you.
Great, thank you. So let's see. I mean, undilatable lesions is a huge problem, obviously, and sometimes we run into problems. Do you think here something could have been done to prevent this, or this unfortunately just happens?
Yeah, I mean, I think using rota here seemed like the obvious next step. If you can exchange out for the rota floppy wire, that's always the biggest issue, is if you can't get a microcatheter down, and you have to decide whether to lose that and try to wire with, you know, a shortened rota floppy or something like that. But in that case, it makes a lot of sense to me. One question I had is, with the 1.5 burr, did you stop because of the dissection, or were you unable to make that corner?
Unable to cross.
It wouldn't go any further. Because I am more leery of the smaller rota burr. I don't know about your guys' experience, but for this reason exactly. But you guys did a great job managing it.
Yeah, they often say that the smaller rotor blur is more likely to get entrapped, and unfortunately you had no other option. So, I mean, kudos to you for carrying through with this case, knowing it'd be difficult and also rescuing it. Just one quick question: what was the time duration of the case, and how much contrast was needed?
Not much contrast because of the dissection. We didn't inject more, and about the time, it was about dealing with the complication took about 45 minutes, and all the case didn't take so long. The wire at the first passed a lot from the first trial, so it didn't take so long.
Yeah, it's wonderful you had all this equipment available, and many of us are not familiar with every name that you used, actually. So you know, your arsenal is obviously well equipped, and you need that to deal with these types of lesions.
Yeah, sure.
And I noticed you didn't have the pacemaker, I think, placed initially.
No.
Do you guys, for most of your RCAs, I think this would have been helpful just to prevent the whole Brady situation. I'm not sure it would have been that much helpful with the entrapment, but what do you guys do?
It was for a short time. The bradycardia shock took very short time.
Short.
Yeah.
Yeah, many people think that with rotablator, if you use short runs, that you can now get away without using the pacemaker. I've done that, especially in the left. We don't worry about it, but the right, you know, I think with the complexity of this case that you anticipated from the calcium, the CTO, once you started using the rotablator, I think it would have been reasonable to put it in. You know, obviously it's easier to say that in retrospect, but you know, sometimes it goes across easy. But if you can't get that, once that 1.5 burr didn't go, I think you're encountering more trouble, and there's more risk involved.
Yeah, I think from the guys in our lab, it's about 80-20, where 20% will do it up front, and the rest will just kind of wait and see what they need.
Yeah. Okay, that's great.
Thank you.
Any questions?